Here we have the bladder, and I talked about the position of the bladder in relation to different phases of life, right? I need to not go back into here. The superior surface is covered by peritoneum, and you can see it's got small bowel, even sigmoid, sometimes even transverse colon and submental will come down here and become stuck. So before you push the needle blindly into even the chest, ensure that the bladder is distended. This is again in the man with the vast difference of de novo, the uterus coming back. And we have the rectal, the cycle, pouch.
It's upsetting though.
It's showing the urethra more in relation to the uterine and the tubular. Okay, that's the back of the bladder, which you'll have already seen, the base of the bladder. Okay, this diagram is just showing you some of the arteries to the urinary bladder. Its main arterial supply. So this is the superior surface, right? So it's going to the superior surface within it. Superior vesical artery. And look where it's coming from. Look at that fellow. Let's trace what happened to the other division there. You know what that is? Yes? That's the obliterated umbilical artery. With me? So the superior vesical artery comes from the umbilical artery, and this is the patent proximal part of the umbilical artery. With me? Continuing to develop the superior second to the superior surface left. The obliterated part will develop the medial umbilical ligament. You see that? Let's look a little further down. A little further down. Going to the lower inferior aspect of the bladder now. It's the inferior vesical artery. Both the superior and inferior vesical arteries are coming from the anterior division of the internal iliac arteries. Okay? It's coming from there. So we have the superior and the inferior vesical arteries, which supply the bladder. These are the two mainstays, arterial supplies. But in the vicinity is the uterine artery there, and it will send some branches down. We have the vaginal artery there, we'll send some branches down, and we show you the vas, which is really coming out from the inferior vesical artery. These are additional supplies. It is said that the obturator artery, which is this fellow speaking to the obturator canal, will also supply as well as the inferior gluteal artery. So the urinary bladder has a tremendous arterial supply, and they are not in the arteries that form a rich anastomotic network. The primary ones are the superior and inferior vesical, but they get additional branches from the uterine, vaginal, middle rectal, obturator, and inferior gluteal artery. The venous drainage is the plexus, vesical plexus, usually the inferior aspect of the bladder. In the female, it's just there, but in the man, it's into the prostatical vesical plexus. And from this vesical plexus, they will drain to the internal iliac. So these are not shown. They drain to the internal iliac. Okay. Now we're showing you the female from the, this is the fundus of the uterus, the bladder. The peritoneum from the superior surface of the bladder is reflected backwards onto the uterus, climbing over its dome, and then from the posterior aspect of the bladder, onto the rectum. Yeah. And we all know the pouch is just like this. And we get to say the non-bilious fascia will separate the two as well. Here we have the bladder resting on one of the support. So here is the schematic diagram, the pelvic diaphragm, which is the A9 muscle. Posteriorly, it's just the rectum in the man, but now we have the vagina intervening and this cervix there. And you can see where, especially this one, where the uterus is pretty close to the lateral part of the vagina, and we said that stone, the uterus can develop here. Similar picture showing that the base of the urinary bladder, posterior aspect is related to the vagina, yeah? Here it is, and to the cervix. Okay? So that is the base of the bladder, posterior. The antepartum uterus is just resting on the surface of the bladder here. And you also had yesterday's headline newspaper about a family came in that in Princess Margaret, where a couple, the wife was terminated, the uterus was empty. I'm sure there must have been miscommunication on both aspects, both people, because human nature, they don't do abortions in public hospitals. And we as human nature, we're lazy. We're not going to do extra work and like an abortion when there's no need. Okay, similar features. Cava practice, uterus cycle, pouch and leg. Dominus pouch there. We have the round ligament very laterally. And this is the fallopian tube with the ovary there. Those diagrams are fairly straightforward. I don't need to spend too much time on this aspect. Similar. Here we have the fundus of the bladder. We have the body. That term are commonly used by the anatomy for clinician, the tribune, and the bladder neck. It's just showing you where into the retropubic space of cava presbyter, the arcuate ligament, clitoral and dorsal vein, and this is the upper surface of the transverse perineal membrane covering over to the living, the A9 muscle, we have the obturator canal, so this is the obturator internal to the fascia, we have the white line after sending it, and we have the levator A, and all of these structures are given support to the urinary bladder, keeping it in its position. It's a similar appearance, the smooth muscle, the smooth appearance of the mucosa epithelium in the trigonal area, where it's trabecular inside a network pattern in the rest of the bladder. And in people with outflow obstruction, especially in men, the trabeculae become even more pronounced, and the mucosa, just like in the older men, as the pressure increases, my perineum signifies a urinary diverticulum. Okay. We have the plexus of veins towards the interior aspect of the bladder there. Here we have the inner muscle, which are helping to support. We have the perineal membrane. And we have the external sphincter just about there. And that's it. A little away from the urethra. In the man, superior surface, the posterior aspect of the bladder, just at about the top of the seminal vesicles, it's reflected onto the peritoneum, onto the rectum. So we have the rectophyseal space. The bladder next is on a very related to the prostate gland there. Similar pictures again showing the seminal vesicle transfixes. Now in males here, as the prostate enlarges, there is a certain part of the prostate gland, median lobe or the central lobe of the prostate gland. As it enlarges, it will bulge upwards into the bladder. Yeah? It will bulge upwards into the bladder. And on cystoscopy, when you look, you will see the bulging of the bladder by this lobe of the prostate. And this area of the bladder is often called the uvula. Yeah? The uvula. So we know about 3 uvula now. One here, the bladder uvula vesicale. Yeah, it's called uvula now, back of the throat, yes? And we have any up here? Yes, we have one up here by the cerebellum, remember? No? So if you are not familiar, I should have used that here.
Oh boy.
This is trying to show you what is not true object in this situation, the enlargement of the uvula by the prostate. We talk about the superficial triangle running down, and it causes a little elevation there, called the urethral crescent, to which we have the urethral seminal vesicles and part of the prostate will empty their secretion. So just at the back of the bladder there, peritoneum has been removed, seminal vesicles, urethra is somewhere, should be somewhere there, and then the vas deferens coming down. This is the vas deferens, urethra, SUV. Those pictures are self-explanatory. This is a representational diagram of the internal sphincter mechanism. This is the female, but it's more appropriate to the man. You have the trigonal layer, the superficial. There should be a deep layer, and then we have the muscular, the middle layer of the true muscle forming the internal sphincter, adrenergic. And the urethra, the control and inner bladder is the external sphincter mechanism. There we are. We have a sphincter urethrae and the compressor urethrae. S2, 3, 4 pudendal nerve, Pons nucleus. The lymphatics start from the submucosal plexus, the muscular plexus, and the adventitial plexus. There are 3, and from those 3 we get an inferior going from the interior aspect of the bladder to the external iliac group of nodes, from the superficial upper from the superior surface we get to the external node, and from the trigonal area they will go to both, but additionally they will drain to the internal iliac group of nodes and to the obturator group of nodes. The nerve supply of the bladder is most important. It has an autonomic nervous component, both sympathetic and parasympathetic. The parasympathetic signal, the sympathetic is coming from T10 to L1 to 2, right? We have the greater lesser than each synaptic nerves, remember them? They come to an either really or more appropriate to pass through the cedar plexus, and then it goes down by the aortic plexus to the superior hypogastric plexus, ribbon, and then you have the right and left hypogastric nerve, and they come down, right and left hypogastric nerve come down into the pelvic plexus. That is what the sympathetic components are doing. And from there they run in the anterior supply to get to the the bladder muscle. S2, 3, 4, over piriformis, the parasympathetic fibers from the anterior lateral part of the cord, remember? They are coming down, and they will form the plexus. They leave as a nerve erigentis, or the pelvic splanchnic nerve. More so, we use the pelvic splanchnic nerve than the nerve erigentis. Also from the motor body of S2, 3, 4, honus nucleus is to the external sphincter, which is the important sphincter for your bladder control. Just as that will show you the channel network. Similarly, when the bladder becomes normally, at first you don't feel any urine, any sensation from the bladder, but as it fills up to about 300 ml, we get the urge to go and pee. And the sensation for that is believed to be going through both sympathetic and the parasympathetic systems. And the fullness of the bladder is believed to go in the dorsal column. Yes? Through the dorsal column. So from this inside it must be through the fasciculum. Yes, so it's not the Q&A answer.
Oh, it's too low.
The pain, when it becomes really painful now, from infection or whatever, they believe the pain is going through the spinal thalamus system, crossing over.
Sweet.
So that is what they believe it is. And I don't know if there are any first year students here. And I think you all should know this very well, because I asked them about this last time in the exams. I don't think anybody attended to this. So, the blue is the ascending thing. So then the dorsal column, or the spinal thalamus fibers, tract, they go up towards the pons. And in the pons there's this reticular formation. There's a midline rapid nucleus, remember about that? And adjacent to that there's this paramedian pons and reticular formation. Well, two areas are important there. There's the M center, the medial center, and that will go down to supply the parasympathetic S2, 3, 4, they choose the A contract. The L will send down to S2, 3, 4 motor honus nucleus and tell it what to do. But furthermore, we will recognize pain or fullness of the bladder more properly. Yes? At a high level, so it's going to go through the thalamus, the posterior nucleus of the thalamus. And from there, fibers relate to the prefrontal cortex, the inferior frontal gyrus. Remember, it told us that the prefrontal gyrus is the part that makes you who we are. You will not want to pee just about in here, you know. It makes the appropriate decisions, etc., executive type of thing. And my joke about concentrating on when you're peeing, in the limbic area there, anterior cingulate area there, remember the gyrus? There's the area that will tell you it's appropriate to pee. And to concentrate on aim right, and some will enjoy the pee. Because I'm going to pastor again, dear pastor. He mentioned about kinky things in relationships. And one of the kinky things was to get a golden shower.
The golden shower?
Represent, comes on dear pastor every night. And he was on last week on his program. Some enjoy a golden shower, and I guess the satisfaction of the limbic lobe system. And right here in the paracentral lobe, remember we told you that your backside is cocking up just over the superior lateral surface of the medial and lateral surface of the cerebral cortex. Remember the paracentral lobule? That is really a perineal representation, and that will relate down to the enough nucleus at S2, 3, 4, and ultimately tell it what to do to relax or contract more. Now, under normal situations, this prefrontal area here will inhibit the limbic and the paracentral, the PAG prematter there, and this preoptic nucleus, which is going to radiate there as well. And it will inhibit. Now, when things are good and the conditions are right, the M sensor from the pons will tell parasympathetic and anterolateral, parasympathetic 2, 3, 4, that choose the A contract. This L sensor now will get stimulation influences from all the way up there, paracentral lobule, and they will come down. And in this instance, for the unit data, it will tell the S2, 3, 4 onus nucleus to relax so that the urine will come out. But you all should be aware of it because it can get injuries to different parts of the bladder, neural pathway. In a spinal cord transection, following the spinal shock, you'll have to catheterize the patient, but when they recover, the lower sacral segment, you get a reflex from the bladder to train the patient to stimulate S2, 3, 4 area, like the posterior part of the scrotum or labia, and the bladder will empty, and that's referred to as automatic bladder. When the surgeons destroy everything, all there is to the bladder in the pelvis and in an operation, then the bladder becomes ruler, self-rule, and that is often referred to as an autonomous bladder. His dorsal affects the dorsal column, so the guy does not know that his bladder is full. But these guys always play domino and drink and wake up. When they wake up in the first morning, in the morning, all the thing is going up. With the shower with pee, so they follow and play the domino and the guys want to go and pee the pee. But these guys, the bladder will come more distended. The here was an automatic bladder, autonomous bladder. Listen to this rather what people start telling you. Then the blood right. And the tabetic type bladder. I see Roy waiting to come run me out, so this was a nice thing.